My today's presentation is on importance of nutrition in adult patient planned for cardiovascular surgeries. So what is nutrition? Nutrition is a branch of science that studies the process by which living organisms use food for maintenance, growth and reproduction of life by the functioning of organs and production of energy. So why nutrition is important in cardiac surgical patient? There is multi-organ dysfunction due to a low cardiac output. In patient posted for cardiac surgery, they have normally a low output setup like multiple valvular heart disease, or there is a reduction in ejection fraction after MI or like that condition. So in setup of low cardiac output, there would be metabolic adaptation of body for that reduce output, cardiac output. That includes endocrine system. There will be reduction in corticotropin hormones. There will be reduction in thyroid hormone, so that body metabolic rate will reduce and to cope up with the low output. Second thing, there would be organ changes in organ also, like in lungs. There will be congestive changes due to reduced left ventricular output. There could be pH changes if valvular disease is there, like mitral stenosis or like that. In liver, if we see if there is severe RV dysfunction, right ventricular dysfunction, that can lead to increased central venous pressure and with reduction of mean arterial pressure. So the total perfusion pressure in all vital organ will reduce, and that can lead to edema formation and reduction in its function. That includes GI tract. It can also malfunction. Kidney, there would be reduction in GFR, and ischemic changes in kidneys can occur. Acute renal failure can establish. Vascular system changes would be acquired type, or it could be a normal. And in acquired type, like patients are having bad habits in form of smoking and tobacco chewing, that lead to atherosclerotic changes. Some genetic diseases are also there that leads to hyperlipidemia, and there would be atherosclerotic changes in vascular bed. So in that type of scene, before the initiation of low output, the vascular bed is compromised. So after establishment of low output, by any means, ischemic heart disease or like that, that can disturb major organ system. In other way, if low output is there, after post-operative period, there would be congestion in vascular system, and due to use of high vasoactive drugs, and due to that, there would be a capillary system dysfunction, and that can increase organ dysfunction. Now immune system can activate in a wrong way, like there would be high release of cytokines and increase neutrophilic count, interleukin level also increase, IL-6 like. So due to that, there would be high formation of inflammatory products like bradykinin, histamine and thromboxane. This system will initiate inflammation in vascular bed that leads to capillary leak and intravascular coagulation formation, and this all leads to reduced perfusion of that organ system, and which lead to dysfunction of that organ. Second thing is acquired one, like malnutrition. Patient is not taking proper diet, like high carbohydrate diet patient is taking, so and relatively low protein intake, that can induce a metabolic syndrome in the patient, and patient could have a high lipid profile and reduce protein level, that can lead to malfunction in form of reduced albumin level, reduced total muscle strength due to catabolic status. So this malnutrition is also sometimes important when we are dealing with cardiac surgery, particularly in poor group of patients. So now what is cardiac cachexia? Cardiac cachexia is a loss of edema-free muscle mass with or without affecting fat tissue, mainly caused by loss of balance between protein synthesis and degradation, mainly result from intestinal malabsorption. So as we previously discussed, due to setup of low cardiac output, inflammatory process increases, and by that vascular bed compromises, and that will induce multiple organ dysfunction, and this is the part of that. So in cardiac cachexia, patient will there would be reduction in appetite of patient will not take any interest in routine activity, will be bedridden only, will step by step lose the weight nearly 5 to 10% per month or like that. So lean body mass will reduce in cardiac cachexia, and that is also affected by endocrine and neurohormonal changes due to low output. Types of nutrition widely divided into macronutrient and micronutrient. Macronutrient includes carbohydrates, fat, protein. Micronutrients include vitamins, electrolyte, and phytochemicals. There are many phytochemicals in the vegetables, fruits, and routine pulses, nuts we are taking in a food that have many protective action like curcumin in turmeric, uh, tomato, lycopene that have effect on malignant cells. There are many phytochemicals that help us uh, very in subtle way to the tissue protection. Now, if we see the what is the calorie expenditure in adult, so primarily we focus on the basal metabolic rate. Basal metabolic rate we can derive from equations. These are two equation major in useful. So and third one is we derive it from indirect calorimetry by use of PA catheter, pulmonary artery catheter. By that we can measure the production of carbon dioxide and volume of oxygen utilized, and by that we can derive the exact energy requirement that body is needed. uh, Problem with that is that in this scenario the energy used by lung is not get calculated. So normally respiratory quotient is of 0.7 to 1. 1 indicates that carbon dioxide production and volume of oxygen utilized are the same. So this is normally occurs in metabolism of glucose, carbohydrate. In other way, like metabolism of fatty acid will lead to that respiratory quotient of zero 0.8. Same way in protein metabolism, amino acid metabolism, it stands between 0.7 to 0.8. So use of high carbohydrate diet in caloric requirement of ICU patient may have negative impact by production of high CO2, and that will lead to requirement of higher respiratory or minute ventilation. That's why we can use minimal possible carbohydrate to get around level of 120 to 180 milligram percent of glucose level. So primarily energy should be derived from fatty acid, and protein supply should be adequate to maintain catabolic status. Second thing, by international guidelines, roughly we can calculate that energy requirement could be at 25 to 30 kilocalorie per kg. Now, second thing is European Society for Clinical Nutrition and Metabolism has suggested some important latest parameter for nutrition in critically ill patient. That includes critically ill patient requires nearly 70% of recommended calorie intake. That we have said at around 25 to 30 kilocalorie per kg per day. So ideally that patients require 70% of recommended caloric intake, because their body is not adapted for metabolize the calorie that we are giving in normally. So uh, it is better to start with 70% reduction, that is less than 20 kilocalorie per day, for initial 7 days to settle the immune response and to nearly normalize the physiological level of metabolism. Protein requirement could be a higher due to excessive stress, like there is a repair process is going on, there is huge amount of inflammatory products is there, so inflammation is also very high. So protein catabolism is very important parameter in critically ill patient. So it is recommended that we should give the requirement, provide the requirement of protein as a 1.5 to 2 gram kg per day for initial 7 days. So the protein requirement suffice, and it will help to maintain means to provide proper healing and immune function for adaptation of stress. Like in carbohydrates, if we select parenteral nutrition, then routinely we prescribe 3 to 3.5 gram per kg per day. But in setup of critically ill patient, we can cut it down to 1 to 2 gram per kg to maintain blood glucose in range of 140 to 180. So as we discussed, it is for the reduction in production of CO2. That's why respiratory minute ventilation requirement will be reduced and total metabolic strain on body will get reduced. Second thing, like in fat, 1 to 1.2 gram per kg per day we can give by fat for energy requirement. It should not be go above 23 milligram per kg in a minute, or better to say not more than 60% of total energy requirement. So otherwise it will lead to ketosis and can aggravate the condition by ketoacidosis. Second thing, in fat, it is very useful to provide essential fatty acids that are linoleic acid, arachidonic acid. So linoleic and linoleic acids are very important for normal homeostasis of prostaglandin secretion. Docosahexaenoic acid and omega-3 fatty acids are also very important to maintain immunomodulation effect. We should avoid the use of omega-6 fatty acid that increases interleukin 6 level and reduces the prostacyclin level. So it is primarily a pro-inflammatory. So we should avoid soy fat as a parenteral nutrition, because that can lead can increase the inflammatory process and can aggravate the medical condition of the patient. Now, route of administration. We can administer nutrition by means of parenteral nutrition and enteral nutrition. Let us see parenteral. When should we go for parenteral nutrition? So, initiate if enteral nutrition is not commenced within 48 hours of ICU admission of surgical patient. That could be many reasons for that. We will discuss that thing in enteral part. Second thing, what is the main good effect of parenteral nutrition? So it improves positive nitrogen balance by providing adequate energy to the body. So the protein catabolism holds and improves nitrogen balance. It provides amino acid to the circulation, and by that the routine requirement, that increased requirement of amino acid is suffice, and helps body to maintain normal serum proteins like coagulation factors, albumin, and there are many proteins, building blocks of muscle. All needs a very high level of amino acid. If it is provided in early time, like then it helps a lot and stops body to enter in catabolic phase. Second thing, it provide a time to normalize the GI function. Like when patient is arrived in ICU and having very high inotrope and vasoactive drugs and with ventilative supports, not maintaining proper perfusion pressure, that is mean arterial pressure minus CVP. If it is less than 50 millimeter of mercury, it is not good to start with enteral feeding, because gastric emptying time, gastric metabolic juices will not be at optimum level, and patient get deteriorated by distension of abdomen or like that. So during acute phase physiology, it is better to start with parenteral. It will bring a time for normalization of normal gastrointestinal function. Now come to enteral. It is less infection because it is not having direct contact with blood. Second thing, it improves patient outcome very rapidly because it is in a very natural physiological way. So patient satisfaction is also great, and second thing, it is physiological, and not possible in some patients that are like intestinal obstruction, patient having distension of gastrointestinal system, gaseous distension, having ileus due to ischemia or poor potassium, hypokalemic, having inflammatory setup due to low perfusion pressure. All this that can lead to dysfunction of GI tract. There could be a infection like anaerobic bacterial colonization can occur in gut and will lead to gaseous formation. Bleeding can also happen, in particular in cardiac setup, by use of heparin, antiplatelet drugs, and add on that due to inflammation there could be a reduction in platelet count and more marrow depression. So that if this is the setup, then we should switch to parenteral before we control this abnormality and make GI tract functional. Second thing, in cardiac surgery patient, we generally use a proton pump inhibitor. So normally, like if you are using pantoprazole, it is a permanent proton oxygenatic cell blocker. So it will lead to reduction, increase in pH of gastric juice, and if increase in pH of gastric juice is more than 2, pH of 2, it will lead to poor gastric emptying. So gastric distension will happen, and there would be a fermentation of food that we give by rice tube. So it is better to check gastric pH of patient, and proton pump inhibitors should be used judiciously if indicated, like a case of bleeding is there, use of steroid, corticosteroid is there, some stress ulcers are there, then we can use this electively. Otherwise, better to switch to H2 blockers and locally acting sucralfate like solution. It is better because it is reversible. So maintenance of normal gastric pH is also important in critically ill patient. If it is not properly managed and alkalosis like pH of more than 2 if occurs in GI tract, it can lead to colonization of bacteria, pathological bacteria, and can be responsible for pneumonia formation by aspiration pneumonitis in controlled ventilation patient. Second thing, high vasoactive and inotrope support patient is receiving. So in that setup, the cardiac output is reduced, like we see main arterial pressure minus central venous pressure, so perfusion pressure if it is below 50. In this status, the perfusion to GI tract would be lower, and if we are continuing that feeding by Ralph's tube or nasogastric tube, then it is possible that food not get properly metabolized, gastric emptying will be low, so there could be an adverse effect in form of infection, distension, and higher ammonia production. So second thing, it can be indicated by raised blood lactate level. Like lactic acidosis is primarily caused by anaerobic metabolism in body. So if there is high lactate in body, it indirectly shows that there is high metabolic insult is there, anaerobic metabolism is there, so oxygen supply is not proper. So we have to focus on that. If lactate level is higher than 5, we should not go for that nasogastric feeding. Metabolic acidosis itself reduces cardiac output, and derangement in vascular bed is also there. Severe sepsis case, in severe sepsis case, if cardiac output is not properly maintained, patient is on high vasoactive drug, then same thing will happen, and we should go for parenteral nutrition until the clinical condition of acute physiology settles. Now some are the micronutrients, like some of them are important in cardiac state, that are vitamin C, ascorbic acid. It is a potent antioxidative vitamin, having anti-stress effect, like it increases the level of body cortisol level. It improves the collagen formation by making and strengthens the wound, formation of steroid as we said, absorption of iron. Second thing, vitamin D, D3 is important for many cellular mechanisms. One of that is immunity. It's vitamin A and D both are fat soluble vitamin and is normal concentration required for proper functioning of cell mediated immunity. Second thing, its effect on myocardium and normal skeletal muscle. It is having effect on myocardial contractility and skeletal muscle dysfunction. So its deficiency can lead to myocardial dysfunction, including skeletal muscle dysfunction also. Vascular bed is also having smooth muscle, capillary sphincter level, so their dysfunction can be also there. So if vitamin D level is below 20, it is clinically very significant low level, and we should go for it for correction of this level. It will help a lot to get proper functioning of myocardium and vascular bed. Second important macronutrient vitamin is thiamine. Thiamine is vitamin B1, and it is having very crucial role in lactic acid metabolism. Primarily, pyruvate dehydrogenase is the main hormone that is regulated by thiamine. If there is inadequate level of thiamine, that body can't use pyruvic acid, and that pyruvate will go for anaerobic metabolism and will increase lactic acid. So the conversion of pyruvate to acetyl coenzyme A to start aerobic metabolism, it is very crucial. So in low cardiac output setup, we should go for the use of thiamine as a pharmaconutrient therapy. Second thing, in cardiac patient, due to edema and third spacing of fluid, so myocardial, there would be a fluid overload. So we use a diuretic with that. In diuretic, as it is a fat soluble vitamin, it get excreted from urine, and so the most of the patient of cardiac dysfunction patient placed on chronic diuresis therapy are relatively deficient in vitamin B1. So it is better to use its supplement in critically ill patient that is having a severe malnutrition. Some minerals are also important, like potassium. Potassium is highly in intracellular environment, and its function is having high value in cardiac, like it increases. It is important for repolarization, diastolic function of myocardium. It is also important for skeletal muscle, for proper functioning of contraction and relaxation. Serum magnesium level is also important. Reduction in serum magnesium level can lead to hypokalemia, and it is also important for maintenance of normal vasoactive tone of smooth muscle. Selenium, zinc and phosphate are also very important micronutrient in form of energy requirement, and second to combat with immune dysfunction. Now we started appropriate nutritional support by use of enteral or parenteral. Now, how we can assess that our nutritional regime is proper? So there could be, we can assess is by in clinical way, like there is improvement in sensorium of patient's appetite get improved, patient muscle function, strength, muscle strength is also improving. It is also showing a positive effect of nutrition that we have started. Reduction in vasoactive and inotropic drugs that were started before arriving to ICU. That is also a positive indicator. Weaning from ventilative support by reduction in oxygen requirement, reduction in pressure requirement, so improvement in lung compliance and total ventilatory parameters. In vitals like temperature, if we say, there is reduction in pyrexia and control of fever, so it is also a positive indicator. These parameters we can check in acute physiology and chronic health evaluation and sequential organ failure assessment scores. These are very great score. Routine assessment of patient by this score can help us that our direction of nutrition therapy in critically ill patient is correct or not, whether we are getting positive response or not. These are some lab investigation that we can do, like measurement of serum albumin level and pre-albumin level. So it is very crucial and important lab investigation in form of establishment of nutrition therapy. Like if patient is receiving proper intake of energy with normal protein requirement to the body, then there would be a step-by-step improvement in serum albumin level. There would first there will stop the catabolic status of body in form of reduction in amino acid metabolism. So patient metabolism shifts from negative balance to positive balance if albumin level is steady or increasing day by day. Second thing, improvement in liver enzymes, bilirubin and INR. INR is also very important parameter. If patient is very critical and having a bleeding tendency, and we see that INR is raising, then that could be a reason that patient is not having proper supply of amino acids. That could be a reason. So even after normalization of that perfusion pressure in vascular bed, if it is not treated well with coagulation factor, then it indirectly tell us that amino acid requirement could be low. In that type of patient, there will be reduction, serial reduction of serum albumin level will also be there. Liver conjugation and other functions is also important, and bilirubin conjugation is also important. So it is also dealing with normal amino acid requirement and normal functioning of liver hepatocytes. PCT, CRP, we can go for it. Procalcitonin and C-reactive protein says us the what is the inflammatory status of body. So if we track it in routinely, so and its level is reducing day by day, then it guides us that inflammatory markers are reducing, and that is patient is shifting from negative nitrogen balance to positive nitrogen balance. So overall outcome of patient get improved. We can see the complete blood cell count by in form of improvement of platelet count. Second, there could be a higher neutrophilic count, like percentage wise neutrophilia of more than 90% is indicative of very severe inflammatory response, or it could be of sepsis or it could be of inflammation. So control patient physiological condition we can assess by series of that CBC. If that neutrophilia is getting reduced day by day and is optimally achieved below 70%, then we can say that patient outcome is now improving and patient will behave in better way and proper weaning of critically ill patient can be there. Neutrophil lymphocyte ratio is also same, so increase in neutrophil is also very uh, critically important investigation. Control or reversal of this neutrophilic differential count is very important in the critically ill patient in form of reduction in systemic inflammatory reaction, and our treatment is going well. So thank you for your patience.